We're moving away from the old system, from the old way of viewing the patient as a patient, from putting the patient in the pilot seat. Tomorrow's patient has chronic disorders, have diseases that stay for a long time and will not accept to be called a patient. They are still citizens, which means that everything we do in healthcare has to be centered around the patient as a co-producer of healthcare. You have to know your own disorder, your own disease, the way you want to go forward, and everything that has to be that you have to do in order to get well or get better or stay well has to be done in collaboration with the patient and in a more contractual forms of healthcare. Our gap analysis demonstrates clearly that there was a very big lack of a process guiding system for healthcare. We reduced the patient to become an object that was in care of a professional. Instead, we have created a process guiding tool that guides healthcare irrespective of where the patient is situated in the system. This process guiding tool allows the patient to be a co-producer, knowing what's coming ahead and also knowing what he or she has to do herself in order to improve health. And it also, of course, deducts quality measures on the way, which means that we can raise flags for anybody who needs extra help. The 4D program is we aim to integrate the research process with the care process and have a fully integrated information system, allowing us to do full research quality studies in healthcare directly. This means that the patient is a co-producer of the data. The patient has full control of the process that goes on and is able to also influence the way the care is done. The 4D program allows full collaboration environment with the patient and the care. So if I have diabetes, for instance, I can agree together with my doctor to get a reminder every second day to go for a walk. I can agree together with my doctor that I deliver all my blood sugar data from my home to healthcare. So when I come to healthcare the next time, you have the full time curve, including I can also get an agreement to go and take my blood sample. So next time I come, I have also a full curve of the HbA1c in order to follow the diabetes, which means that I have a full time control with much more intensive follow-up of the patient, which we have shown motivates the patients to really follow the treatment. The culture of medicine is very, very isolated from the culture of behavioral medicine and behavioral science. And what we have done is that we have integrated the two very clearly with clear science on the behavioral science side and not the old paternalistic medical way of doing it, telling the patient you should do it. Instead, we have the agreement culture and we have the feedback of information to the patient in order to make the patient as well informed as the healthcare is. It's delivered in 4 diagnoses, but we are now expanding it, so we're now up to 7 diagnoses, and we are above all developing generic tools in order to be able to develop healthcare and the way healthcare is delivered. If you take, for instance, breast cancer, all breast cancer patients in Stockholm are included in the program, all, and that's 2.1 million patients, which means that we get several hundred patients every year that will give material to the biobank. They will participate in development and they will also be pilots of their own disease trajectory, which means that the quality as such will be ensured throughout the whole system. And we already have in international terms pretty good outcome measures, but our aim is to become the really top-notch of the world in treatment outcome in breast cancer. The information that we collect is of a size and it covers a full population. So it becomes internationally a very unique database. We have with the 4D program a completely unique databases. There are two things that are unique with them. First of all, it's a population base. It's not a patient cohort base, it's the population. So it's all patients with that diagnosis within this region. That's one thing. The other thing is that everything we do is done in a structured way. Structured semantically and structured in terms of how the databases are made. Which means that we can harvest the databases for care and for research and also for population statistics. And we can do that independently of one another. And we have also built in a full control of the data to the patient. So as long as I give you my informed consent, my data is present in the database. With the moment I want to take away my consent, those are retracted and all there is are black dots, which means that you can do proper statistics in spite of the fact that the raw data is gone. Well, the result so far is that we've gone from 40% consent to allow your biomaterial go into a biobank to over 96–97%. We have decreased the time to by having on the internet a small test for joint pain, and that's coupled to healthcare. That sends back a flag and say you can go there in order to follow up your joint pain. We've been able to demonstrate that we can shorten the time to diagnosis several months, and that's the period where today most of the joint destruction happens. When we look at this in terms of data integrity, you have to look at integrity from both sides. There is one integrity, and that is whether somebody who is illegitimately can look at my data. That's a problem. But you have another thing, which is also invasion of integrity, and that is that I have given my information because I trust healthcare to give me the best health. And if I go to you and then suddenly I'm exported to another care unit and they don't have the information, how do I know that they know as much as you did? Which is an invasion of my integrity as a person, because part of my integrity comes from trusting healthcare system. So what we are building is that we're building a net where the patient has control of the data, but the data is shared as long as the patient wants to be part of it. The interesting thing that we have found is that when now the patient does most of the data collection and does a lot of it at home, is that we can guide the contacts with healthcare and space them and save healthcare time. That's one thing that we have found. Another thing that we have found is that patients don't accept to be viewed as a patient because they go there to have some sort of intervention and then they're out again. And so there are several really big cultural shifts that are coming from this way of working. Stockholm has the fewest hospital beds of any westernized country. But we have many care beds in local community care, which means that we have very short times in acute hospitals and the university hospital. And most of the care for those with many ailments, many diagnoses, that's done in community care. And by separating those two, we can professionalize also the care component, which is in dire need of improvements of quality. And now we are moving those data together, which means that we can inform between units along the patient trajectory, as long as the patient would like to participate. Our next step is to really improve this and demonstrate to the world that this is the way to go. Very simple. We want to demonstrate that it's possible in ordinary healthcare to have the patient as the pilot for the trajectory and to be able to produce data that's high quality for healthcare quality measurement and for research.